Good morning, my name is Nathan Way. I'm a student at Grand Canyon University in DNP 848. My professor is Dr. Michelle Dixon. Today is September 11th, 2024. This assignment is the Patient Care Delivery assignment where I'll be discussing my DPI project Proactive Rapid Response Team with early warning. It's known that clinical deterioration in hospitalized patients is not usually just a sudden event, but a progression of subtle signs of decline that can result in negative outcomes. Failure to rescue is a common term that's used to refer to missing those subtle signs and not escalating care sooner. This is a process of a reactive system, and it's not often just a miss, but a nurse is busy and she might miss those signs. Subtle changes may just mean a slight increase in respiratory rate combined with a 2-point jump in the white blood cell count. These types of changes may go unrecognized for hours or even days. So when intervention can be applied when they're found, the patient could be better, but when not, they're worse off. Rapid response systems have been in place for many years now, and they've done a lot to improve outcomes, but they're limited because they're reactive and they're dependent upon the nursing only approach. Escalations in care are positively correlated with increased mortality, as shown by Dinesh et al. In their work. Delays in rapid response activation can lead to an increased risk for escalation in care, and this has spawned the development over the past few years of early warning systems and digital early warning systems. Escalations in care in this context and with the Dinesh et al. Project are synonymous with upgrades to the intensive care unit. In terms of that, they also point out, and in many articles, that escalations to intensive care when the patient has been on one of the wards is also associated with increased mortality. At a practice level, at this hospital, the rapid response team is largely reactive, not proactive. There is an early warning system already in place called the Epic Deterioration Index, but it is rarely referenced by the clinical team. Nursing staff is not required to do anything using that number. It just kind of exists within the background. Beyond that, there's been an upward trend in rapid responses resulting in movement to the intensive care department. This is just some data from the practice hospital. This is actual data showing 2023 compared to 2024. And while many of the months there has been a decrease, it can be seen that in May there was an increase and there is an upward trend for this year in those events causing escalation of care to the intensive care department. This does not include as well upgrades to the intermediate care department coming from rapid responses. So the strengths of our program is that there already is a rapid response nurse practitioner in place to assist with assessing and managing patients. The structure of the rapid response team is enhanced because there's 24-hour coverage. These individuals serve as the team lead for rapid response events, but the rapid response is also staffed by charge nurses from the floors and the other units, not just the unit where the patient is at. They serve as kind of the workers, and then NP serves as the team lead, sending orders, requesting assessments, and diagnostic testing. The EDI, or Early Warning Tool, Epic Deterioration Index, is already embedded into the electronic health record, which is great. There's no excess cost associated with this. It exists, it's there. There's even some alerts that take place when a patient's score goes too high. And so that is already of benefit when we begin educating and referencing. And then the rapid response nurse practitioner, this has been discussed in principle with her, as this is individuals where the student works with, and they agree in principle to the project of moving from a reactive process to a proactive process. Essentially what will happen is the team will get together in a room, they'll review a proactive swim lane board, and they'll be able to sort patients based upon their risk level and decide who they're going to go see. From a weakness perspective, the hospital is very used to rapid responses being called in a reactive way, not a proactive way. So moving in that direction is going to be a major change, and it's going to require change management. One thing to note is that reactive rapid responses, or recognition of decline that's sudden or that may not have been picked up during the proactive rounding process, remains in place and remains okay. Nothing will change in regards to the staff's ability to request assistance also the patient's ability or the family member's ability to request an immediate assistance and assessment by the nurse practitioner. The other weakness is seen is that awareness and engagement with the tool is still limited. Staff are not required to do anything with it. It just kind of is existing in the background. Nursing staff have so much that they have to be doing, and when something is not required of them, they often overlook. Opportunity, early recognition and intervention remains an opportunity in this hospital and hospitals across the world. Beyond that, there needs to be a coordinated process to review every shift with the charge nurses after nursing assessment is done. And nursing staff need to understand the accuracy of documentation. That is one of the risks to this project, or one of the threats, is that although the EWS is automated, the score that develops the EDI comes from multiple data points, many of them being subjective, such as nursing neurologic assessment, cardiac assessment, and respiratory assessment. If the nursing staff don't document timely or do not document accurately, that can create false positives or false negatives, which can either send the staff looking in the wrong direction or missing the patients that really need their intervention. The proposed solution simply is that the rapid response nurse practitioner will be in partnership with the unit charge nurses, and they'll huddle every day at 11 a.m. after AM assessments are completed, because our shifts start at 6:45, and 11 p.m. The team is going to work together. They're going to review the large board, which is a television screen with a computer, showing each patient admitted into the hospital, into the inpatient departments. It shows their room number, it shows their trend of data points over the past 24 hours, and it shows the color category that they're found in. For the EDI, low risk is green, medium risk is yellow, and high risk is red. Usually red would mean greater than 60 or 70, depending upon hospital individualization of the tool. Those patients that are found to be in red, or found to be trending up towards red from the yellow category, or even trending rapidly up from green into yellow, would be reviewed and discussed. The benefit of doing this proactive surveillance using the early warning tool is that the team can have a discussion with a practitioner and a nurse who are actually caring for the patient. The charge nurses are responsible for all of the nurses in their departments. They can be there to at minimum prior assess those patients and prior review their charts to see what's going on, and then talk to the nurse practitioner so they know where to focus their efforts. For example, if a patient in room 5 is actually on hospice, but their EDI trend shows red and consistently red, the charge nurse can let the rapid response nurse practitioner know that yes, we're aware that this patient is high, but they're high for a known reason, and this is an expected outcome. On the other hand, Mr. Johnson in the other room, this is a fake patient name, shows a rapidly increasing trend. I went to see him and he's breathing a little faster and he looks worse than I saw him yesterday. I think he needs to be on the list to be reviewed. From there, the nurse practitioner takes that list of patients that she would go, or he would go proactively review, and actually assesses them within the chart, or immediately goes to the room to assess those patients, depending upon their perceived risk of the situation. They have the ability to order medications, order interventions, and they also have the ability to call the patient's attending physician or even consultants and discuss a concern that they're seeing, which often can be taken more seriously in a more rapid situation than maybe if the bedside nurse had paged. This meets organizational needs. For one, there's no increased organizational cost. Each member of the care team that's part of this process is already employed by the hospital, is already working in the role that they're in. The EWS tool, EDI, is already embedded in the medical record. And so really the only added cost that's going to come with each of these stakeholders, medical staff, nursing, quality, critical care, nurse practitioners, and others, is through a one-day, 4-hour training where each individual will learn more about the project, learn more about what needs to be accomplished through the project, and that would be considered non-productive time for non-salaried employees. That would be around $1,200 as has been calculated. This is a visual depiction of the change process. The early warning system is operating in the background using the EMR, using those data points that contribute to the EDI, and then shooting out a data point which is trended upon a graph. The collaborative meeting takes place where the team reviews the high-risk patients according to EDI, and then the team, either together or the rapid response nurse individually, will go visit those patients, review their medical records, and apply intervention should that be needed, or provide reassurance to the bedside staff. Intervention, should they take place, are documented within the medical record. These items can be tracked using Epic reporting. And then with hope, the patient improves without need for ICU care and can discharge home. The expected outcomes are decreased length of stay, as was seen by Heal, Sylvester, Guerrero, and Coates in 2017 through a similar project of proactive rapid response using early warning system. Decreased mortality, as was seen by Escobar in 2020, and decreased ICU bed utilization, as was seen in what I'm calling my flagship article, Dinesh et al. 2019, decreasing ICU bed utilization, which is can be some of the costliest bed utilization in the entire hospital. From a financial perspective, referring to DNISCO 2023's basically diamond showing the four basic functions in healthcare, which is financing, healthcare organizations, employee organizations pay for patients' insurance and help to subsidize those costs. The federal government helps to subsidize costs through paying for insurance and other services. And even patients pay themselves, or hospitals kind of take that hit and write off losses from patients that are not paying for services. That financing brings in the ability to seek care of patients. Care is delivered by medical providers and physicians. Payment comes from insurance companies who were financed by the employee's organization or the government, and they pay for those services, and it just continues in that cycle. Some of the barriers in there would be utilization controls on the delivery side, capitation and discounts on the payment side. Insurance companies and CMS don't just pay what hospitals bill. They pay based upon diagnosis-related groups, which is a capitated cost or capitated allowable amount dependent upon what the patient's disease was. If the patient stays longer days than the DRG would have originally paid for, the hospital actually eats that cost. Beyond that, that patient is taking up a bed that another patient who may be of paying status or within the parameters of their DRG could be using, which is considered lost revenue. Beyond that, ICU is the costliest in the hospital. And so when patients have to go to the intensive care unit, they require costlier nurses, costlier physicians, costlier devices, and overall hospital billing for hospital beds is higher. They're also at a premium. Beyond that, Centers for Medicare and Medicaid Services, CMS, requires public reporting of mortality rates in many different disease states. So the public can go and they can see healthcare providers choosing to come work for the organization or not, can see how is this hospital performing. Do I want to bring my patients there, or should I bring them elsewhere? Risk underwriting is something that has to be considered by any healthcare organization. Healthcare organizations are providing a very sensitive service to individuals. With that service, just like in any other industry, there comes risk, there comes error. Failure to rescue events create a very high risk scenario for healthcare organizations. And this is why this student's DPI project, in terms of hoping to prevent those failure to rescue events, helps to mitigate some of the risk that may come from litigation on a life that was lost, or something that may have been able to be prevented.